And thank you very much indeed. It's a fascinating talk. And yeah, I was particularly encouraged by the number of trials that are involved at the moment. And that's quite a surprise. That's fascinating. We've almost completely run out of time, I'm afraid. So the number of questions, I have to limit the number of questions. But there's a general one here, if I can, and that is, should we be contacting our consultants to ask about personal risk, or is it just one's own assessment? You've covered this in your talk, I know, but it's worth re-emphasizing, I think.
Okay, sure. Risk is multifactorial, and risk is something that we interpret ourselves. It does depend what we have to do, and work, and our economic priorities, and what we want to, where we want or feel we need to be, and how much pressure we might be under, or you might be under, to go back to work and worry about your working environment. Of course, talk it through with your consultant and with your key worker. There may be aspects of your immunity that you're not aware of, or just to put into context, that you may or may not have been treated. If you were treated, it might have been years ago. If you've not been treated and your immunity remains dynamic and your body mass index is low, you might be in a younger age group, you may not have any of the other risk factors. So that individual risk is likely to be less than someone with a higher degree of comorbidities, COPD, structural lung disease because of recurrent infections, secondary hypogammaglobulinemia, recent therapy, a low CD4 count at the age of 75, for example. And although it's so difficult to make a scale and codify that risk, I think it's worth having a discussion with your clinical team to try and get an impression of how you are. But there will be an element of personal responsibility and interpretation in all of this. But trying to put that into context and talking it through with your clinical team, and also with representatives and perhaps buddies identified through patient-facing charities as well, is not a bad start. And so I think that's where I would take it with that, Brian. Thank you.
Thank you, Ben. If we have enough time, just a couple of more questions. This is one that's come in this morning. If I'm unfortunate enough as a CLL patient to test positive for the virus, what should I do apart from panic?
I hope please don't panic, but there must be a practical response to this. Okay, so this is clearly very important. There is a responsibility to yourself and to others around you. So firstly, if you are, you must be at home, self-isolate if you are well. And the guidelines are very clear on this. So self-isolating for 7 days, and your household within the same bubble must self-isolate for 14 days. If you're unwell, then there's the NHS 111 online. There's 999 as an ambulance to take you to hospital. There's your clinical team. So please don't forget that you have a key worker, you have a clinical team, a consultant, and the medics involved in your care. And you may wish to discuss with them how you are. You may wish to let your GP know. GPs can sometimes get left out of this, but I think letting your GP know about it. And then if you do get admitted to hospital because of this, then it may not be through your own haematology department. It might be through a different system. So you may need to find that out as well. But in general, being at home, plenty of fluids, monitoring your temperature, and just gauging how you feel, particularly with your breathing. And if you feel in any way unwell and you're worried about yourself, then getting in touch with hospital services is very important. Don't forget the responsibility to self-isolate, and for your family and your bubble to isolate for 14 days.
Thank you, Ben. Very wise advice. Finally, what is the situation with patients needing IVIG treatment? My treatment has been postponed since the lockdown started, and I have missed at least 2 treatments. I understand that part of the reason is that there is a shortage. Is this true?
Okay. So to try and get a balance of risks in terms of footfall coming into the department at the very early stage, when we really didn't know how kinetic this virus would be moving around between staff, patients, and where it would be in patient areas, then the response to this was very, very swift in modifying our treatments and keeping people out of hospital as far as possible. And that included people on intravenous immunoglobulin replacement up and down the country. This is true, and it's true in Leicester also. So the risk of coming into hospital to have treatment on the day ward when your immunity is already extremely low was perceived as being potentially high risk, and that you'd be better off in your home environment and shielding away so that you were not exposed to this virus. Now that situation may change, and I think it is changing at the moment. Antibody levels, of course, will go down over a number of weeks, and that can increase the risk of infection as well. So there's going to be a shift in that balance, and that shift in that balance is around us at the moment. And I think it's worth having the discussion with your clinical team about when they might feel that it is safe for you to reinstate this therapy. As far as shortages are concerned of intravenous immunoglobulin, IVIG is subject to some gatekeeping in any case, so it's not readily available and easily available unless there are key certain circumstances. I've not had a shortage of this drug. I don't think that it's been discontinued because of unavailability, but it is used sparingly for those with specific indications with low immunoglobulin G, infections on prophylactic antibiotics, in people who have been identified as having a failure to demonstrate a dynamic response to the pneumonia vaccines. So for those people, it is available, but I think discussing it with your clinical team to ensure that the environment is safe for you to have it is important.
Dr. Kennedy, thank you very much indeed for a fascinating talk and for your time today. I know it must be a very, very busy time for you at the moment, so many thanks indeed for sparing us the last hour or so. Thank you very much indeed.
Thank you, Brian, and thank you to all your colleagues at CLL Support. Thank you, everyone out there. Bye-bye.
Thank you to everyone for your hundreds who've logged on. A reminder that a summary of all the questions that we were not able to answer today will be on our website over the next couple of days. Please take a moment to complete the very brief exit poll if you can. I believe there were some problems in filling the first one in, but it would be extremely helpful if you could. You need to answer every question, I think, even though it might not be relevant, and then hit submit at the end. We're also, while we're doing that, we are also supporting Blood Cancer UK in a campaign which they've launched called Save Our Shielders. And this is a campaign that's been going for a week or so now to give people with blood cancer that need to go back to work 80% of their salary, so they would still stay under shielding, but would still be furloughed. At the moment, everybody comes out of furlough after a period of time, and this particular campaign, which we're supporting along with our sister charities, is an important effort to try and get some recognition of people with CLL who also have to work. The idea is that you write to your MP. If you can see you could get this on the Blood Cancer UK website, and you can see at the bottom left of your screen there the tag to get there. There is already a letter prepared for you, and you simply fill that in and send it off. So far, I think, looking this morning, there are over 5,000 people already that have logged on and sent it, and we've had reactions already from several MPs. Just a reminder that we'll be holding other webinars. The next one is in September, the 2nd of September, and we'll be giving everyone details online and through our newsletter over the next few weeks. So this is the results of the poll that you've just kindly completed. Thank you very much indeed. This is very valuable information indeed. %, said it was helpful. Excellent. That's an interesting number 5. Well, we can't have conferences. Do you think that webinars are a good substitute? 99% of people said yes. That's fascinating. Okay, everyone. I think we'll close down the webinar now. Thank you very much, everyone, for logging on. It's been a wonderful experience having you all here, and we look forward to seeing you again at the next webinar. Thank you very much indeed, and goodbye.